Well, Brian, Chris, welcome to the podcast. Super excited to talk with you guys today. For people who aren't familiar with you and all the incredible stuff you do in the sports ortho world, would you mind filling in a little bit about who you are and all the amazing stuff you've got going on, especially in this ACL world that we're diving into today?
Sure. So my name is Dr. Brian Lau. I'm an orthopedic surgeon, specialized in sports medicine, dual fellowship trained in sports medicine, shoulder, as well as foot and ankle injuries, and do a lot of knee surgery as well. And I have about 5 years experience with the BEAR implant. And so excited to talk about that.
Yeah, I'm Chris Antonelli. I'm a board certified sports clinical specialist and athletic trainer, and I specialize with ACL rehab and overhead athlete rehab, a lot of shoulder stabilizations, and I have the opportunity to work very closely with Dr. Brian Lau, and I've been with MIAC for about 3 years or so, but working with bear patients for about four. And Brian actually brought me along with some of the first ones that we've been working on. So I've been able to gain a lot of experience over the last handful of years working closely with you.
That's absolutely incredible. And as you guys mentioned, there's this ACL problem or ACL epidemic that a lot of people are facing. And I certainly felt it personally when my dad tore his ACL skiing about 3 years ago. And when it happened to him, I immediately was like, you need to go and inquire about a BEAR implant because when you're in your 50s and you're trying to return to a high level sport like skiing, something like a quad or BTB graft just didn't seem right to me. But this is not something unique to him. This is occurring to hundreds of thousands of people every single year that way. And I feel like the BEAR implant has really solved that problem for the person that doesn't necessarily want to go the tendon graft harvest route but doesn't necessarily want a cadaver graft either. And all while doing that, it spares the joint long term. And there's some phenomenal research about the long term joint preservation that it has coming out as well. Would love to hear your thoughts about just overall this ACL epidemic and where we see the BEAR implant fit into that from an algorithmic standpoint, if you will.
Yeah, so I have insights. I mean, your scenario of your dad that you described is very, very common, particularly with BEAR implants. So skiing is a high incidence of ACL tears, and the mechanism of injury for that is a little bit different. So we tend to see it being pulled off of the where it's attached, rather than when someone's playing soccer or basketball and they make a cut and it kind of the ACL kind of explodes. This one, the ACL kind of pulls off, so it's good tissue. And so you're right, and those tend to be ideal candidates for the BEAR implant, where we can take the tissue, repair it back to the wall, and this implant allows it to kind of regenerate itself. Uh, the other thing you mentioned was long-term health, and the BEAR implant is some really emerging just in the last few months data showing that it could potentially decrease post-traumatic arthritis. So we're really, really good with ACL surgeries, reconstructions, bears, all that is really good. But patients still get arthritis down the road. Is it from the initial injury? Is it from all the inflammation that's in there? Well, we're seeing now that the BEAR implant potentially could decrease that rate by 6 times. Again, that's early studies, but that's really promising studies in terms of long-term health of the knee.
Yeah, I think, what's been neat to see is, we've, from a rehab standpoint, I've seen the Bears being highly successful for people of all ages and all activity types, from people, your dad, that are active recreational athletes to some of these people that are more high level high school football players, lacrosse players. And for the patients we've worked with have been some of these high school athletes. But then we've had a handful of people that are just trying to get back to daily life, which is parenting, going to work, having a stable knee. It's really neat from the PT perspective of just seeing the wide population of patients that are appropriate for this implant, and just the success that we're having early on. And I think we're still going to learn more and more as we go, but I'm having a lot of success with these rehabs, and a lot of people feel really good, which is great.
How do you find patients are initially learning about the BEAR implant? Are they coming to you and they said, hey, look, I asked AI and it told me to inquire about this? Or are you the first one to bring it up? Or where does this kind of enter the conversation for y'all with the patients?
Yeah, that's a great point, and I think there's been an evolution of that. When we first started doing it, we were kind of bringing it up a little bit, but now most people come in knowing about the bear, and they're asking about it, whether that's from AI or from friends or from online group chats and stuff. I'm not sure, but a lot of people are coming and asking about it and trying to inquire about more information. But there are a few patients that come in that we look at the MRI and we're like, could be a really good candidate for it. And we do bring it up. But I say most patients now are coming in with that knowledge.
That's huge. And I think having that knowledge early on allows the conversation to just flow better, because a lot of times I've talked with people in the past that are like, well, we've done BTBs for 20 years. So how do I bring up this new, different thing when this is the way it's always been done? But to your point from before, if this is something innovative that has promising outcomes that can really decrease some of these different long-term effects that we're concerned about, it needs to have a seat at the table, in my opinion. I think the other point, and you brought this up earlier, Brian, is the concept of what tears are right for it and which ones are not right for it. And I think you were describing the avulsion type injury before. It sounded like that way, but I think I've also seen it used for the mid-substance rupture, and I've heard some different things about enough of a stump present and enough of good quality tissue. So what kind of things go into it from your end in relation to who's right for it versus who's not right for it? And just the pre-op PT that they might be doing with someone like Chris, does that have any impact on that or influence on that?
It's a really good questions there. So um, you can use the BEAR implant for, like you said, proximal tears, mid-substance, or distal tears. The main thing that needs to be there is there needs to be good tissue. So it needs to have some integrity to it, wherever that tear is. And that tends to be most of the time when it's proximal. But you can have mid-substance tears that have really good tissue that we can bring back together. But so it could be for all, but most of the time it is for more proximal tears. And and so we older patients, that tends to happen. Patients who are more recreational skiers and stuff. But there are younger patients who can have an injury, whether playing soccer or basketball, where they actually do have more of a avulsion type injury. And so, the short answer is it can be all of them, but it depends on the tissue on the MRI, and ultimately when we get in the operating room. So when we get in the operating room, we will tell every patient that's considering a BEAR that we have to go and we have to look at it, we have to pull on the tissue, we have to make sure it can hold suture. And if it can, then it can be eligible. But even if the MRI looks perfect, we could go in there and it may not be eligible for a BEAR. So, and then for your pre-op PT question, it's still important to have good range of motion, whether you can do a BEAR or an reconstruction. But I'll kind of lean that over to Chris and see what his thoughts are about prehab.
Yeah, I think it's just like any other like ACL technique. I think prehab has been highly beneficial. But I think one of the key differences here when they are coming in for prehab with the anticipation of having a BEAR implant procedure, it's a lot of the education piece, because it is going to be a different rehab compared to a traditional reconstruction. So we're able to talk about some of those key educational pieces of what to expect with these rehabs, but a lot of our principles are going to be looking the same. We're going to try to calm the knee down, reduce some effusion, swelling, try to restore motion, try to get that extension back for certain before heading into the operating room. Try to get their flexion as best we can, and usually we have some pretty good success with that in terms of like isolated cases, and then trying to strengthen them. So a lot of the prehab bowls would be similar for this BEAR technique versus other techniques, but a lot of it is just inquiring about, like, hey, what are we going to be expecting early on? How's this going to be different? And just trying to set them up for the best success that we can.
Anecdotally, preoperatively, I've loved the use of BFR as well. And this is totally opinion based, but I felt like there was some type of correlation between tourniquet time and their postoperative quad function that way. I've noticed longer tourniquet times seem to have a longer time to get their quad back. Have you noticed any difference on your end with the tourniquet times if you're doing a BEAR implant versus a tendon graft for an ACL? And on your end, how do you feel the patients who have had a BEAR implant get their quad back? Do you feel like it's quicker, about the same, or a little bit slower than those that get a tendon graft harvest? And does that vary at all by the tendon graft they've had, Chris?
So I'll answer the part about the tourniquet. So anecdotally, I can't say that I've seen a big difference. I tend not to use tourniquet. When I do, it's simply because it's a bigger case and there's more going on.
Yep.
So that would definitely be a confounder of why maybe their rehab is a little bit slower. It's because it's a little more difficult, a little bit something challenging happened.
Mhm.
And so I'm not sure it's related to the tourniquet usage, but I think that you can see some differences between the different grafts and the BEAR implant. And Chris probably know better about that.
Yeah, I think definitely what we're seeing is improved quad function earlier. There's definitely the decreased donor site morbidity that compared to a quad tendon autograft or a BTB. So with that, typically these patients have less pain, less swelling. There's still swelling present, of course. They're still in some pain, but the quad function is fantastic. And sometimes that's one of the harder things because they feel pretty good pretty early. So we're having to rein them back. But with that, we're still leaning into BFR for sure. I'm a big believer in that. I've had some great success anecdotally. We're still utilizing a lot of NMES, all of those classic ways to try to improve quad activation early, but it certainly does. The quad certainly does come back with improved function earlier than some of these other cases. And I think that allows people to just get a little bit of their independence back earlier as well. And they often feel better. But then a lot of it is trying to rein them back in a little bit because they do feel pretty good early on just due to that.
How early are you seeing them post-op? Is it the next day or?
When I work with Brian, yeah, I see them next day, which is great. So we're able to get them in the door. We're able to then go into a lot of the educational pieces. A lot of it's like some classic, we're just post-op dressing change, going over the initial restrictions, those types of things, and then getting them started on some range of motion and quad activation exercises. In other cases, at most 3 to 5 days post-op. I love seeing them 1 day post-op. I know some people have different opinions on that. I think we've had some good success with 1 day post-op because granted, it's a lot for the patient at times to get there just because they're 1 day out of surgery, but a lot of patients really appreciate that kind of hands-on interaction. They've learned a lot from Dr. Lau and the surgical team at the surgical centers, but sometimes it's a whirlwind, and they get in there and they just have a couple questions that they've already gone over, but they just want some more clarity, or man, they're like, wow, a lot happened at the surgical center. So we're able to just educate early on, change the dressing, get them feeling a little bit better, and kind of give them a little bit more peace of mind early on.
Absolutely. Does anything in this process change when it's more than just an isolated ACL? Maybe they've got some meniscus involvement as well, or perhaps, I'm not sure if you've done this yet, Dr. Lau, but I've heard some people talking about maybe including a Lemaire or a modified Lemaire into the conversation with a BEAR implant as well, which I know some people love, some people are not quite there yet. I'd love to hear your thoughts on that and if that changes anything from a rehab standpoint as well.
Yeah, so certainly if they have a concomitant procedure, whether it's meniscus or, cartilage or anything else that comes with it, that will change the rehab. It doesn't change it too much. I'll let Chris talk about the early BEAR rehab, because there were some changes in terms of where we compare it to reconstructions. But in terms of your question about the modified Lemaire or the lateral extra-articular tenodesis, which is becoming more and more common even for our reconstructions, and especially high-risk patients, whether that's returned to a high-risk sport, patients who have re-injury tears, or patients with a little bit more laxity. We're doing that more and more even in reconstructions. So actually, over the last several years, it started involving more, even with the BEAR patients, doing that as well. So, especially in younger BEAR patients, where we know that risk of re-tear for even reconstructions is high. All right. So even in those risks, I'm going to try to do everything I can to decrease that risk. And doing the modified Lemaire or the lateral articular tenodesis as well. And just what that is it helps protect some more rotational instability and decrease the rates of re-tear. That doesn't change my rehab protocol, actually. When I add that in, the rehab protocol stays the same.
Yeah, I'd say from our rehab standpoint, some of the kind of key differences with the early post-op phases when we're thinking about a BEAR versus, I'll initially touch on an isolated ACL reconstruction. It would be really the main difference are the first 12 weeks or so. With a BEAR rehab, without a meniscus repair, we're talking about partial weight bearing for about the first 4 weeks. And we're going to be on a more of a progressive flexion, meaning the first 2 weeks, we're only going to flex somebody from 0 to 45 degrees, trying to just respect the early tissue healing. Then from weeks 2 through 4, we're going to start flexing a little bit more towards 90 degrees. And after 4 weeks, we'll gradually restore as tolerated. And then we're considering a meniscus repair, like a concomitant meniscus repair with the BEAR. Then we're also thinking about, okay, what's occurring in terms of this ACL with this implant, but also how are we respecting the tissue healing and minimizing stress of this repair? And that's where working closely with the surgeons, understanding the BEAR component, but also meniscus rehab on whether it's maybe they're non-weight bearing due to the meniscus component, but that's not necessarily due to the BEAR component. It's having those conversations with everyone involved with the rehab process, the surgeon, the patient, any family members. And those are going to be some of the key differences. From an LLT component, it's what we've been seeing, it's not any different in terms of that aspect of the repair. It's more so if there is some meniscus involvement or maybe a multi-ligament component to it. Those are going to be some of the key changes in the rehab process.
It's interesting because anecdotally, I've seen early on with those LEP procedures, they can be a little tighter, a little stiffer sometimes, but long term, and I'm not sure if this is just the education that people get or something, but the return to sport confidence levels just seem to be a little bit higher in that population. Anecdotally, I'm not sure if it was just felt more solid and stable to them or all the education or what it was, but I certainly thought there was something to that. Now, the component about the restricted flexion, Chris, is that more so in relation to the tibial rotation component and the screw-home mechanism, or do we have any kind of concerns around that following the BEAR? Because I know with the traditional ACL reconstruction, there's a lot of debate on should we flex them too far, or how far should we flex them early on? Should we have them do weighted leg extensions, longer quads early on? And there's a lot of debate around that. Does any of that conversation change with the BEAR implant or still a case by case?
Yeah, so definitely we're treating everyone on a case by case. But what we've actually seen over the last handful of years is the BEAR protocol has evolved. So initially we were definitely more on the conservative side. A lot of it was trying to gather data, do some research, and we were trying to control a lot of the variables. So early on, we weren't even advising passive range of motion, which a lot of colleagues were like, well, why is there no passive range of motion? And trying to educate people on, well, when we're rolling out, like the BEAR folks, MEOC team as a whole, when they're rolling out a new procedure with new protocol and gathering research, just trying to control as many variables as possible to prevent too many cooks in the kitchen from doing too many things to potentially change some outcomes. What we've learned is that range of motion, passive range of motion, active assisted, active range of motion is all in theory safe, right? It's all minimizing extra stress on this native ligament. And that's where then the restricted motions in the protocol come into play is this native ligament that is being repaired. It's now going to be in like this type 3 collagen early on. And it's going to take time for this. I consider like a wet spaghetti model. You have this wet spaghetti ligament that has decreased tensile strength. It takes time to go through the ligamentization process. So from there, we're just really trying to prevent over stressing this ligament early, which is where this guided restricted motion comes on. So it's just going to be preventing too much stress too early, and it would be the best way to sum it up.
Yeah, no, that's huge. And to me, anyways, from a physiological mechanism, I could see how that approach would maybe reduce your rate. And this is all anecdotal for the record of that second procedure needed, whether that be a clean out or a debridement or something that breaks up the scar tissue, something to improve range of motion. Because with your approach, the way you just outlined it, it's paying respect to the physiological healing as opposed to just we're going to crank on this thing as hard as possible. And I think a lot of times when individuals mess up that early phase of rehab, they do too much too quick. And now we have an angry knee, it's irritated, it hurts to move, so it doesn't move. One thing leads to another. And then the next thing you know, they have to go back in for a second procedure because we've lost range of motion. When at the time of surgery, I'd imagine they had full range of motion before you closed it up. So it's very intriguing to me how that early phase can really lay the foundation for the rest of the rehab if done correctly, or cause it to fall apart entirely as well. And, I'm sure we've all made a mistake there in the past or two. Like I remember my first post-op ACL rehab. We definitely went a little quick with him, but it all turned out well in the end. So I think it's important to note that early foundation lays the framework for all the fancy stuff that people love to see on the Instagram later on, right? The force plates, the return to sport, all that sort of thing. It's like, if you don't master the first 2 to 3 months, none of that is going to happen, unfortunately.
Couldn't agree more. And I think that's one of the key things with most rehabs, but in particular ACL of any variety, but a lot of these bears is it seems relatively conservative if you were to look at the protocol or have some conversations with people that are rehabbing them a lot. But it really is so important to just master these early phases of just restoring extension, restoring flexion gradually, and then just really advancing some quad activation, quad strength, progressive hip strengthening, because that's what's going to dictate their long-term success is getting this knee. Sometimes we feel like we want to do more than we need to. We got to be a little bit fancier, but we got to, I would say to any students that work with me, you got to just stick with the meat and potatoes of the rehab, hit the foundationals, hit the fundamentals, and that's going to set these people up for long-term success.
Absolutely. Postoperatively, Dr. Lau, how often do you see patients who have had a BEAR implant, and what does that visit look like? I'd imagine with you working so closely with Chris, you get a lot of updates on them regularly through the portal, through notes and that sort of thing, and that kind of PT surgeon relation with this patient population is probably absolutely essential, I would imagine.
Yeah, I mean, we're very fortunate that we have a very open lines of communication between our team and as well as their physical therapy team, and that definitely helps out a lot. So that now, early postoperatively, patients are generally feeling pretty good because they don't have the graft morbidity. Now, and then there's always concern, as we mentioned, because there's a slightly limited range of motion that we protocol to have early on, that they'll lose motion, but we really don't see that. Patients are generally getting their motion back. It might take slightly longer, but they get their motion back. Particularly that flexion is what people worry about um, later on, and they get that back. And one thing I would say about their patients, they tend to be very informed. As I said, a lot of patients come in and are aware of things, and so they're on top of things. They're very good patients to deal with, and they follow the protocols. They will listen to Chris and the team, and they make sure that they get their rehab done, which is just as important as the surgery. The surgery is important; it's time zero, but the rehab really, kicks off how well you do in long term.
How does that conversation change when return to sport starts to enter the picture? What is the timeline around return to run and then return to sport from there? And what criteria are you looking for from both of you that way? Is it, still quad index, hamstring index, that sort of thing? Or are there maybe new developments that we're looking into as well?
Yeah, so that's a great question. And the common question we get in terms of the BEAR implant and versus reconstructions is their overall time to return back to play. And right now, it's still kind of keeping us the same. There's obviously really good data out there that shows anytime getting back to play before 9 months increases your risk potentially double or even sixfold, depending on the study you look at. And so we still kind of followed that, in terms of time period, at least 9 months. There are objective things that we look at, and we're fortunate to work very closely with our P team to do that. And so we do have some functional testing that we use. So to look at and criteria objectively, but also from time standpoint. And I'll let Chris talk about the functional testing.
Yeah, so big believers in objective testing. We're letting tissue healing timelines help dictate some of this, but a lot of our decision making is coming down to our objective testing, and we as a team have kind of talked about how are ways that we can be the most consistent. So if any one of us in our clinics and our facilities are working with these BEAR patients, everyone can feel comfortable that we're all on the same page. What we've decided as a team is we like to get an isometric quad test at 12 weeks, whether that's with a handheld anemometer or on a isokinetic machine. We're trying to capture some data, and that's going to help dictate readiness to run. So we're ideally looking for minimum of 70% quad index if we're going to start somebody on a assisted running device, like a unweighted treadmill or like in a pool type variety. Then looking towards about 80% quad index if we're going to get someone really traditionally like running. But then for more of the sport specific type movements, we're really looking at quality movement as well. So how do they tolerate pre-running activities and then just straight line running? What are we looking at from a introduction to agility? Do they have the movement mechanics? Looking at some of those just pillars of movement, eccentric quad control. Do they have confidence with this? Giving them some psychological readiness questionnaires. But then around the 6 month timeline, that's when we're getting our full physical performance test. We're looking at isokinetic data. Big believers in capturing that if you have access to that. Introducing the single leg hop test, incorporating some force plate data. And we're fortunate to have all of these resources. We're trying to capture all that to see what would a single leg vertical jump look like in addition to the traditional single leg hop tests. Then even we capture some ligamentous laxity data with the KT arthrometer just to see how subjectively, how do they feel, but objectively, what's the stability. So those are all making our informed decisions. And then we use that and we just do serial testing throughout in terms of how they respond to running. Then from there, they progressing appropriately with our still loading programs. And then we introduce them into the more agility-based training. And then we just keep moving stepwise through that. And we're constantly checking in with them to make sure that their psychological awareness is improving just as much as their objective outcomes in terms of functional performance.
What have the two of you seen in relation to the arthrometer data in the patients who have had a BEAR implant versus maybe a tendon graft that way? And on top of that, you mentioned return to run, you mentioned all these other things. I've seen this approached 10 different ways by 10 different PTs, right? It seems like we don't have a universally accepted way to do that. I know there's a lot of great protocols out there. University of Delaware, Columbia, Dr. Ahmad has some good stuff, but everyone seems to approach that differently. So what's kind of worked well for you anecdotally with the patients who've had a BEAR implant as we start to get them back to some of these more sporty type activities, if you will?
Yes, I'll answer the KT1000 data. We've looked back at our patients, BEAR implant patients, BTB and quadriceps patients, and we're seeing that even at 6 months and the 9 months testing, that their laxity is essentially equivalent. And so there's not a difference in that, as you might suspect it potentially, but there's not. And so that's really promising data. That obviously is something we look at. Obviously on their exam, we're double checking all that, but at least in that laxity data, objective data, is very, very similar between the BEAR implant, BTB, and quads. I'll let Chris answer the other question.
Yeah, I think in terms of like getting back to the running and some of the higher level athletic activities, there's a science component to it, and there's definitely the art form component to it. And I think a lot of it's dependent on your clinical scenario. Like, how often are you seeing these people? Is it a little bit more high volume where you can see them perhaps 2 to 3 times a week? Is it someone that's coming in 1 time a week? Or sometimes at this point, a lot of people are feeling very good. So it's more of that like recreational athlete, or those folks that they've got a job, they've got families, all those, or maybe we're checking in once every 2 or 3 weeks. A lot of that comes down to, okay, how can we best meet this patient with where they are to meet their needs of, we're doing the objective testing. We have the data. Now let's just kind of roll out. If it's those folks that come in once every 2 to 3 weeks, let's give them a 2 to 3 week program on, all right, let's just return the run now. We're not trying to get too flashy with it. It's like, let's see their movement quality. How does their movement quality pair with their objective testing? From there, what are some things intervention-wise that we should work on, whether it's force absorption, force production, maybe it's just their cardiovascular fitness. Maybe they're just a little bit deconditioned from, maybe that was at baseline, or maybe it's because of the surgical process. They just haven't been as active. So trying to meet them where they are. But a lot of times it's that true art form, the science of blending everything together. A lot of the positive encouragement, hey, things look great. We just got to continue to progress with, let's get you a little bit more fit in terms of getting you back to running the man. It's that way then we could advance more of these sport specific things. Because I find sometimes, at least in my practice, when we get into these recreational, even something like the high school athletes, to get them back to those what we think of as higher level sport aspects, sometimes we're limited by just like their fitness level. They just become out of shape, and it's going to happen. It would happen to any of us. So just try to progress those things, so then we can be more successful with a little bit more intensive movements and activities, or perhaps those movements that could perhaps be a little bit more higher risk if they are perhaps fatiguing or deconditioned.
It's so funny to hear you say that, because that was the biggest mistake I made with that first patient post ACL, was the fitness level just was not developed. And then I started to pick up on some of these other things that we could do to actually condition that. And it wasn't necessarily all included in PT. Sometimes it's multidisciplinary, right? Like sometimes you need the strength coach involved, you need the AT involved, and so on that way. The more hands in the bucket in this case, if managed well and in a team environment, the easier the process becomes, I think. And I think even having them like sit down and do battle ropes or sit down and do a ski erg, it's like something to get the heart rate up early and often seems to help that early on that way. The other concept, you brought up the ligamentization process again. And Dr. Lau, I'm curious, as you see these post-operatively that way, when they fully ligamentize and heal, does it look more like a single bundle, kind of like a tendon graft ACL, or does it look more anatomically correct, I guess I want to say, where there's maybe 2 separate bundles that have kind of formed after that bridge is repaired, for lack of a better way to put it?
That's a really good question. So there's 2 ways to look at that. One is an MRI or intraoperatively. There's probably a little bit more data on MRI, and we look at for somebody has a tweak or something and they want another MRI, and we get the chance to look at the ACL again. And generally, we're seeing that the orientation of the fibers are normal. It does take time to get there. It can take about a year to get there, but the orientation, the look of it looks like an ACL, a native ACL. Fewer patients, but occasionally we have to go in with patients who may have, a second injury from someone like a meniscus injury or something else that goes on that we have to go in a second time to look. And when we go in there, it looks like a normal ACL. There's always a normal, a little tiny bit of laxity when you pull on it with your probe. It looks and functions like a normal ACL. And again, these are patients who typically had good tissue on them the first time. So it's normally that same tissue that's there and it's now attached and back to where it needs to be.
That's huge. And the other thing I wanted to bring up earlier and just kind of circling back to it, when you have that concurrent meningitis injury, I know there's some different research that came out showing that drilling into the bone to get that bone tunnel releases some factors into the joint space that might help that meniscus repair hold better and improve the outcomes of the meniscus repair. Is there anything that you do intraoperatively, whether that's biologic augmentation or anything like that, when you're doing a meniscus repair with a patient who's also getting a BEAR implant for the ACL?
That's a great question. So typically, if I'm doing something for meniscus, I will vent the notch to try to replicate kind of drilling a tunnel, get it some air to come out. The BEAR implant, though, is trying to do a lot of that stuff already.
Right.
And so there are some studies ongoing right now and some early data to suggest that the BEAR implant can protect the meniscus and help the meniscus heal too. So there are studies out there that are looking at just isolated meniscus and whether or not the BEAR implant can help with that too. Data's still out there. We're still learning about it, but that's something's on the horizon. We're trying to see, like, can this help meniscus heal without having to drill tunnels and do all those different things? Because you're right, we're trying to stimulate all the cytokines and marrow and everything else to try to help this heal. And so that's a promising area for the BEAR implant. When it comes to ACL and meniscus, I am doing some notching. We are drilling I use an anchor technique, so I do drill some tunnels there to kind of again stimulate that. But the hope is even with isolated meniscus, that potentially BEAR implant can be helpful too.
And to your point, there's certainly a physiological process. I know we talked about that earlier in play here. And that's something that I think oftentimes, especially in the physical therapy, emphasis on the physical space, people like me have maybe forgotten about because we focus so much on the physical, right? How big is it? How much does it move that we forget about the underlying physiology that goes into that? And going back to Chris's point before on the overall fitness levels, anecdotally, I've seen maybe some like metabolic health correlations with overall outcomes from an ACL, meniscus, any real sport injury to the knee that way. Have you seen any other maybe underlying physiological variables that might impact someone's outcomes from this, whether that's early on or later stage that way? More respect to the underlying physiology than just some of the anatomical and force output considerations alone.
Well, yeah, I mean, there's definitely many components to how people are successful after an ACL. You could do the exact same surgery on 3 different people and have 3 different outcomes. So there's definitely many different reasons why patients do well. One's the rehab, one's the surgery, one is definitely the physiology of it. I think we're still learning about that. I think that what those different factors are, whether that's mental health, whether that's our religious side of things. We have studies ongoing right now looking at the different cytokines. We're pulling some fluid off at the time of surgery to see how that compares and relates to outcomes down the line, because that can also affect post-traumatic arthritis down the line as well. And so I think that we're still learning about what those factors are, but there's definitely factors that are part of that.
Chris, you mentioned about the force plates as well, and I feel like that's become the latest like black box that a lot of people have opened and almost get lost in at first because you get 7, 8 pages of numbers and it's like, where do I begin with this? And at least personally that way, I love the counter movement jump and I love the braking phase of the counter movement jump. I think for whatever reason, looking at how well someone utilizes the stretch shortening cycle post-operatively has given me a lot of information. And I'm also a big fan of DSI calculations to see how are they doing when we compare the jumping to maybe like a max effort ISO force output with a belt squat or a thigh pull or something like that. Has there been a certain direction that you've led your staff and clinicians into relating to how they analyze force plates and break them down and apply it in more of a systematic and framework-based approach instead of just looking at pages of numbers and saying, where do we go from here?
Right. No, you're definitely right, Dan. There's you can capture so many metrics, so much data. And truthfully, we're still trying to figure it out. We're still trying to get on the same page of what do we want to look at, what's valuable to us, how often should we utilize this? Is it too overwhelming for the patients? It's very much a patient case by case determination of what we're looking at. And I think sometimes we're using it as data capturing, which I'm a big fan of the counter movement jump myself, as well as just like some single like hop testing with that. But a lot of it's even using it just feedback of hey, let's see how you're moving. Let's look at some of your movement quality. Here's some of the data that's associated with what we're capturing, but what are some other ways that we need to intervene to help just some of the movement quality that we're capturing as well? So sometimes not getting so bogged down in the true data science component of it, but using it more as like a learning tool of like, hey, this is areas we're lacking. This is where our force production is maybe great. This is maybe where we need some improvement. How can we then intervene? What are some things that we can be working on together, as well as with perhaps like a strength coach or a personal trainer on their own at the gym. So using it as a resource for patients, but then also as a training tool, but then also as a data collection of, hey, here's going to make this informed decision making for true sport processes. But I know sometimes I can be overwhelmed by it, truthfully. So I'm curious to continue to learn about it and continue to implement it. But it's hard with, I think, personally, there's sometimes we have people that are interested in capturing some things and others are trying to capture other things within all the force plate data. So we're trying to get everybody on the same page, I think, at least for our facilities, it's still a work in progress.
And it's a never-ending cycle.
It is.
But one of the things you hit on that I think has been super beneficial with it is a lot of the athletes, especially if they're at a Power 4 university, they've got force plate numbers pre-injury. So it's like, hey, now can we start to compare what did they look like before versus where they're at now? And even just overall like jump height or like rate of force development where we compare the force outputs to an actual unit of time, right? It's like, hey, we might be getting the height, but the strategy is different. Maybe the counter movement depth isn't the same. Whatever it is, we start to get insights that maybe we wouldn't before. And I think ultimately, the more data points you can collect, both in the moment, but also preoperatively, especially if they're coming from a Power 4 program that has those things already, the more informed you can be in the process that way. Uh, do you take those reports and then send something like that over to Dr. Lau's office? And if so, Dr. Lau, how do you recommend surgeons start to incorporate or break down the sports science element? Because I've heard some surgeons who expect it now and they want a force plate report from everyone that they work with that way from a PT standpoint. I've heard from others that say, hey, look, we don't even have them in our own place because we don't think we need it yet.
Right. Well, yeah. So, I mean, I think to your point, there's more and more information and data we're getting from a rehab standpoint.
Mhm.
And trying to coordinate and understand all that stuff can be a challenge for some surgeons, but it is really important. I think you're talking about some of the pre-injury data comparing to post-operative. That's huge. Like if you can get that and have them, we had that, like you mentioned, for some of our athletes. It's really easy. Like, oh, yep, they're back to where they were, and you're ready to go. But I think starting to understand that, I think some of the ones are, you mentioned kind of movement jump and stuff like that. Just some basic ones to understand as a surgeon is really important. I try to use that and incorporate that into the rehab and understanding, and when we're having the discussion with the patient. So all the functional rehab stuff that we've just talked about earlier, as the kinetic hop testing, is incorporated with the force plate data, and so I'm able to go through the whole report. We talk about their patient-reported outcomes, their readiness. So there's a return to sport index that we look at as well, and being able to have all that information there can really give the patients like, oh, they really are making sure that my knee, not just my ACL, but my whole knee is ready to go back. I can confidently go back. I'm ready. That part is critical as well. So I think if you can incorporate it, and then I think many surgeons are going to appreciate that, and it's going to only help with the recovery and also patients getting back safely to the sport.
I could not agree more. I realize we can talk about the ACL, the BEAR implant, the rehab process, and so on all day long that way. Is there anything we missed as we were chatting today, or anything we didn't get into that you two really wanted to cover?
Yeah, I mean, so we're in terms of the BEAR implant, I think, when I describe it to patients, a lot of times we get asked, what is the pros and cons? Okay. And so I say the one, thing to keep in mind, we're still learning about it. We've been doing it clinically for about 5 years now, and patients tend to be doing well. If you look at some of the early data, that was all in very strict protocols and randomized controlled trials. Now we have some of the BEAR registry, which is more like real life data, and we're seeing how that papers compare. And the one thing about the registry is that surgeons have adapted the procedure and modified it, which is different than their initial studies. So if you're looking at the real life data, the re-tear rates are about 8% right now. Okay. If you break that even further and you look at patients and they're looking at their standard technique, or the ones that were described in initial studies, those re-tear rates are a little bit higher. And the re-tear rates when people have modified it are lower, around 2 or 3%. Okay. And I think that's important to keep in mind, because when these real life data, surgeons are making sure they're doing them on ideal patients. They're figuring out which ones are the ideal patients, and they're doing techniques that are going to work a little bit better. So working with surgeons who are a little bit more experienced with the BEAR is important. But I think it can be a viable option if the tissue is right and good. And just keeping those in mind in terms of those numbers, because it's a very common question we get asked.
Yeah, and I would add, I think from the rehab perspective, like the BEAR implant, the rehab, it's different earlier on, and I think sometimes that can be overwhelming to clinicians. Perhaps those clinicians that maybe maybe they don't see high volume ACL rehab in general, so when they get a BEAR implant, they get a little bit timid due to that. Or maybe it's people wherever they're located, their surgeons are just starting to ramp up with those. I would just encourage like any rehab provider to lean into the resources. Miak Orthopedics has so many great resources on the website. The protocol is there, which has been updated in 2026. There's a continuing education course that we've rolled out, and that's to be updated as well in the upcoming months. There's also a PT Finder link that you can find on the website, where if you are a patient who's looking for someone that, whether it's a physician, whether it's a PT that has some experience with this, the MEARC prides themselves on trying to train clinicians, teach clinicians through webinars, the opportunity to have discussions like this, so more and more people can gain comfort and have these educational experiences and exposures to learn from other people that have more experience. So there's resources out there. I think there'd be it's a great way to just connect with people in the field. So if you're a PT, if you're a patient, feel free to reach out to the MIAC team. They can direct you to who would be a best fit for you to learn more about this. There's patient resources, there's rehab provider resources, there's some links to some of the research that you've addressed as well. There's a lot of information out there, so hopefully it won't be as intimidating, but I feel a lot of questions from colleagues about like, hey, I haven't seen one of these in a while. Can you just bring me up to speed on it? So then we're going to continue to learn more. I think we're going to continue to evolve just like everything else. But I'm really excited to see the future of this. But just there's a lot of great resources out there. And I think you're doing a great thing by bringing something like the BEAR to more accessible to more people just through this podcast opportunity.
And it's so funny to be sitting here with you, full circle moment, because about a year ago, I was on one of your Kind Ed webinars teaching people about the BEAR implant and the rehab process. So it's a crazy full circle moment. I'm a true believer in it because I've seen it personally. And I think that this has the ability to change how we approach the ACL long term. So I really appreciate the opportunity to talk with the two of you about that today. And I can't wait to see the continued work that you two continue to put out there.
Thank you.
Thank you so much.